We're jumping into the cortex removal portion of cataract surgery, and one thing that you notice is there's quite a bit of movement of that lens.
And the capsule itself, the capsular opening, does not stay around. You can see how it's jiggling around, everything is dancing. So this hints at a zonular weakness that seems to be not localized, but overall nothing is perfectly stable.
And the zonules are these real tiny little string-like fibers that go 360 degrees around the lens and hold it in place.
360 and also anterior to posterior. So not just one ring, there's fibers inserting in the front and further back, which is why, for example, a vitrectomy tends to loosen the posterior attachments of the fibers and weaken them. Marfan syndrome, pseudoexfoliation, all can weaken the zonules as well. To explain it to a patient, I oftentimes compare it to the spokes on a wheel that hold the hub in place. And if those spokes get weaker, the hub can move, and in this case, the lens can move.
I'm already intrigued because I see this ring and I'm thinking to myself, how are you going to get that into the patient's eyes? And that's what we're going to see.
A safe but very slow insertion of this ring. Usually the capsular tension ring, you can use an injector here, place it manually. The injector would straighten out that ring and then insert it in one motion. This is a particular design of a capsular tension ring that has waves. I believe it's called the Henderson ring, and that allows, should cortex still be there, for the cortex not to be trapped, because otherwise if you have a round ring, you put it in while cortex is still in, it's difficult to remove the cortex from behind that capsular tension ring. Here, those little waves allow you to remove it in between.
Now, there's one condition, and I don't know if we can comment at some point about capsulophimosis. Is this going to help prevent things like capsulophimosis, where you get that extra scar tissue, like shrink wrapping of that capsule coming in towards the center?
Yes, because it, again, extracts attention outwards, and you can see how I use that little tool in my left hand to push that ring in so it doesn't get caught on the anterior rexes, but as you can see, I'm having quite some difficulty. The other reason for me polishing the anterior capsule is to prevent phimosis, and in somebody who I'm already concerned about the weakness, so you saw the little motion of that instrument that kind of sweeps back and forth, that was to polish the anterior capsule and again decrease the chance of the anterior capsule contracting. The reason why that's a concern is, I'm so sorry, the reason why that's a concern is that the contraction can pull off more zonules.
And you can actually see just a little pulling of that capsule. You can see how it's flexible tissue, and that ring is just getting worked in
slowly, slow and steady. As long as it goes safely, I'm happy to take my time. It would be nicer with an injector, but again, as long as no harm is being done, I'm happy to do this step by step and moving one little edge and corner forward at each motion.
Would the injector collapse this down into a smaller, tighter space so you could get the whole thing in the capsule all in one injection?
It more straightens it out, and then it injects it through a tube, so as it's injected it curls, but that injector then keeps the other one, the rest of the ring straight, and as you inject it, it goes around.
But I like watching this full length just to show the efforts going into trying to stabilize this patient's capsule, because this is going to be well worth the effort to provide a more secure capsule and bag, and that would be the preferred location to place an intraocular lens. So if it can be used, by all means, let's try to use that space.
Correct. And also, should the patient ever need a secondary fixation, should the whole lens bag complex dislocate, the capsular tension ring that's inside the bag can still be used to secure the whole complex to the sclera.
Yeah, I think we're about to see the little boing
disappear. Yes.
And it's gone, and now it's stuck in the capsule where it's going to remain. And the lens comes in next.
And then after the lens, the removal of the viscoelastic. And what we watch for here is to make sure that the lens centers well. The one piece tends to be nice because it unfolds smoothly and easily with less force and distortion. And at the end, the lens centers nicely in the capsular bag, and the whole complex doesn't wiggle quite as much as it was initially. You see a little shivering, but otherwise it's more stable than it was before the capsular tension ring went in.
Is it fair to use the term phacodenesis in this case?
Absolutely, yes. That's what you would see, and afterwards you would still probably expect some pseudo-phacodenesis, meaning the artificial lens that moves slightly.
Got it.